All right, you guys, Dave Mad Max 6, and this is a very special Ask the Doc episode today. We actually have a very prominent guest with us, all the way from Greece, Doc. So we have George Touliatos. Welcome to the show, Doc.
Hello, David. Thank you very much for the invitation. I'm a big fan of Dr. Rob McLean, and we have some friends in common. We share the same passion about age management, longevity, and hormone replacement therapy and bodybuilding.
So I'm really happy right now because I have two actual doctors who have practiced bodybuilding, who love bodybuilding. It's their passion, who are now in the medicine side. And I'm very excited about this show because I think it's going to speak to a lot of people to be able to talk about HRT and TRT from a bodybuilding standpoint and medicine standpoint. So Doc, thanks for being here today. And Dr. Ren, I know you're very busy. It's right before your day. Doc's at the end of his day, so we're going to get started. Today,
my pleasure.
Today I wanted to talk about bodybuilding and hormone replacement therapy and testosterone therapy and heart attacks. If there's any correlation between the two, what your medical opinion is on that, and what could possibly be prevented, or how could we use HRT and TRT and being safe doing it, especially when men gets into their later 40s and 50s and so on. So we obviously, Dr. Rand, have a common friend, Eric Brozer, who just had a massive heart attack. Also, the bodybuilding community will know that recently Charles Poliquin died at 57 of a heart attack as well, and that touched a lot of us that are into the bodybuilding community. So I want to get your take on that and what you guys think about this subject.
Yeah, no, please, Doc, I'm interested in hearing your thoughts, please.
Yeah, absolutely. Thank you, Dr. McLean. So I believe that the hypogonadism, because the reason to go through a replacement therapy is to be diagnosed with primary or secondary hypogonadism. So the hypogonadism is related with metabolic syndrome and diabetes type 2, non-insulin dependent. And there is a correlation with obesity and dyslipidemia. So if you don't manage your hormonal profile and it's not optimal, then I guess it should be linked then with dyslipidemia and insulin resistance and the mental fat that also releases other cytokines like interleukin-6 and Q-manipulation factor. And also the glycated hemoglobin goes up. Therefore, if you're super low in testosterone and also LH or FSH are also do not respond, then I assume you are closer to heart disease, and especially if your diet is not properly or if you don't exercise. So then, I was hypogonadic because I come from the bodybuilding community, and I was abusing, of course, anabolic androgenic steroids, and I was diagnosed with secondary hypogonadism in age 40.
Sorry.
So yeah, I met my mentor in Italy, Dr. Spatini, and we decided that I should start. And then I noticed that after a couple of months, when my testosterone was stabilized and optimized, my HDL and LDL and my total cholesterol were perfectly modified. So my HDL is over 40, my LDL is below 100, and my total cholesterol is below 150. And of course, my glycated hemoglobin is below 5% because when you use testosterone, you build muscle, and this is reversely proportional with mental fat. Plus muscle regulates the glucose receptors, and you can absorb more glucose, so it doesn't float, and then you don't have this kind of insulin resistance. So I believe that optimal testosterone levels and not superphysiological is ideal. Besides, it is proved that testosterone releases nitric oxide, which is a major vasodilator in coronary arteries. So yes, it can improve the vascular supply, and also testosterone and androgens modify the calcium and the magnesium absorption. And we know that calcium plays a major role in heart contraction. That's it. That is my That's my point.
Dr. Ryan.
Well, I'm not a cardiologist, obviously, but to add to what Doc is saying, I think it's important to reemphasize what he notes, which is too low can be a problem, hypogonadal, but supraphysiologic can also be a problem. And of course, the addition of anabolic steroids, all of which will change your lipid profile for the worse, can contribute to, at least one major factor in the development of coronary artery disease. The sugars, just to go further from what the doc said, keeping those low are important because we know that high sugar in the blood can lead to inflammation. He mentioned the fat, especially around the omentum, releasing cytokines, inflammation, and we talked about this prior to the show. Inflammation will take those building blocks to which we're referring and make them into a problem. So, it's multifactorial, and I think it's fascinating, Doc. You said you didn't let us know what the lipids were specifically, but when you went on to therapy, you got those numbers that you stated without doing any additional things, but simply reversing hypogonadism. You didn't have to go on metformin or statins or anything like that. You got such perfect numbers?
Well, not in a regular basis, but occasionally I'm using niacin, krill oil, rice yeast, chromium picolinate, alpha lipoic acid, vanadyl sulfate, phytosterols, and some agents, to improve my lipid profile. And of course, my diet is perfect, and I do also regular cardio and resistance training. But I have to tell you that when I was on gear and right after my shows, my HDL was single digit, was below 10. My LDL was close to 200, and my total cholesterol was 250 plus. It was messed up, everything. And I had to reverse this at least in 8 weeks. Of course, I was using statins and a Mediterranean diet and all this supplementation, and I had to be patient and wait and do cardio. Of course, I was blessed not to smoke or not to drink, but it's a long process to reverse your dyslipidemia, and especially statins do not affect HDL. They only lower LDL and total cholesterol. So HDL is very stubborn and does not listen very well, and it picks up very slowly. My only concern about replacement therapy and testosterone replacement therapy is the increase of blood viscosity. That in my case, my hemoglobin is always above 17 and sometimes goes up to 19. And I have this kind of, I am, genetically predisposition. So
2 gene mutation.
Predisposed, yes. So the blood viscosity forces me to use a baby aspirin on a daily basis and to keep my platelets low and deactivated. I have erythrocytosis, but I do not have polycythemia vera. But it is a fact that androgens stimulate EPO from kidneys that increases hemoglobin. So my only concern is this, and especially steroids that increase also fibrinogen, which is it is a clotting factor from the liver that also makes more sticky the blood. That's why steroids induce clotting, And on the other hand, they also increase INR, which is a clotting factor that promotes more bleeding. So if you have a cut, it doesn't stop in 3 minutes, but it stops in 5 minutes. So it's controversial, but it is a fact.
So Dr. Ram, what do you think the best advice would be to our bodybuilding listening community right now? They're going to compete. They're going to take not only testosterone but all kinds of other compounds as well. First of all, is there anything that they can do right now to see if they're prone to heart attacks? And if they are, is there something they can do to make sure it doesn't happen to them? Or what would be your best advice?
Doc?
You want to take that one, Dr. Ryan, or?
Sure. No, I mean, what I tell patients all the time, whether they're using anabolics or on replacement therapy, no matter what the assays look at, is, the assays are a gauge of your risks, some of your risks, the risk factors for developing coronary artery disease. Of course, depending upon the assays, specifically the lipid panel, but also some of the cytokines to which Doc mentions. But really, why are we looking at all those things? Bottom line, why do we care about cholesterol, for example? What we just talked about, coronary artery disease. So the best way, I believe, is to go and image the arteries, say, okay, what is the condition of the arteries? Because as we both noted, there are people that come in with lipid profiles that look disastrous, or I've seen them where they look perfect. I had a 56-year-old male who suffered a heart attack, and I went back and I looked at his labs, and every single one looked perfect, no risk factors. So wow. Again, it's purportedly a 30-year process of building up. So it's not emergent when you see just kind of a side note, an LDL of 190. It's something you want to consider, obviously. But by the way, as I said before, I'm not a cardiologist, but the recommendation to get a bilateral carotid Doppler ultrasound as a first go at imaging is from our over here in the States, best in the West, UCLA, Dr. Stefan Room, who's the head of cardiothoracic imaging. He says, look, if you're clean at that point, because there's a 95% correlation between what we see in the carotids and the coronary arteries, you shouldn't, there's no need to go any further. But if you do see a speck here, then go ahead and go further and do imaging in the coronary arteries, whether it's a calcium score or full, CT angio, whatever you think is more appropriate based upon this. And that's really where you start, because that's what all this really amounts to, all this worry about lipids and inflammation. So I'd start there. And if you're, 35 years old and you've been doing, anabolics and maybe pushing the limits a little bit, remember that training hard makes for more inflammation. I mean, it's part and parcel of it. It goes back to the doc's earlier statement about, really hitting the middle, the optimum mark, not too low, not too high, whether it's with testosterone or your training or your eating or anything. But get a beat on it, especially if it's in your family history, and see where you're starting. If you're clean as a whistle, that's a pretty good sign at age 35. That's so far so good. But just like with anything, continued monitoring, I think, is the secret here, whether it's for this or cancer, because early detection, so you can make the adjustments, is most important. Would you agree or have anything to add, Doc?
Yes, absolutely. And what I also want to add is the observing homocysteine and LPA, lipoprotein A, that they can show a deeper thing than just the lipoproteins and the total cholesterol. So homocysteine should be kept below single digit, below 10. And LPA also, there are some certain standards that should be below 20, for instance. And it's related also with genetic predisposition. Some people are more prone to heart disease and have very super high LPA. And in order to keep low homocysteine, you can use B12, folate, and betaine to methylglycine. And some people believe that niacin also can lower LPA. And personally, I have noticed this. 2 months every summer, I use a little bit of DECA along with my TRT. So I use 50 milligrams per week to have some joint relief, and a bit of pumping. It's not something special. So I do this for about 8 weeks. And I use it along with my testosterone, and also in Greece we have Proviron. Proviron is DHT. And I have noticed that using 50 milligrams of Proviron a day, 50 milligrams of DHEA a day, which I also use it 3 years every day in a row, and also with 100 milligrams of testosterone and 50 milligrams of nandrolone per week, I don't see any serious deviation of my lipids. And okay, my body composition is okay, it's acceptable, but when I wanted to increase the dose and make it higher, then I notice my HDL will drop, my lipids, my ALT and AST maybe will go up to 50, my liver enzymes, And of course, my hemoglobin is going to go sky high up to 90.5. So I have to undergo therapeutic phlebotomy every 12 weeks. And I have to give blood, even though I am rhesus negative and I'm a global donor. I can donate to everybody. They have to throw away and waste my blood because it's super high, and viscous. Some people are very lucky, and their hemoglobin doesn't go up higher than 16, and they're and I envy them, because it's nerve-wracking to undergo this phlebotomy and the super thick needles.
Dr. Ryan, I know we spoke about this in previous shows and stuff, but what would you consider, and obviously Dr. George seems to have found the perfect, dosage and levels for him to be, quote unquote, normal or perfect. But what would you say, what would be considered above HRT or physical dose?
The supraphysiological dose is, it's semantics. I mean, you could define it based upon the norm, obviously. So I shouldn't say it's just semantics, but supra optimal, I guess, would be something to consider as a new word. We've established since the 1950s that you're not going to get clinical benefit from replacement therapy unless your total testosterone, and of course, this is how long ago we're using a measure, because we were, now we use free testosterone much more so because we know that's where the rubber meets the pavement. But 800 nanograms per deciliter was sort of the given on average, but I don't think that was part of a nice, neat Gaussian curve. I've seen people come in and, their average is much lower and much higher than 800 in terms of a threshold over which they have to maintain to achieve the clinical benefit. I think, at least in the United States, most of the doctors who are using TRT in their practice are used to prescribing about a cc, 1 ml of testosterone cypionate, 200 milligrams per ml as a starting point, and then going, from there to titrate it depending upon, unfortunately, in some cases, the numbers more so than the patient, but I like to, talk to the patient first and foremost. With those dosages, for the most part, I find if I'm going to do any adjusting, it's going to be upwards. If someone's what I refer to as an expensive date, they metabolize it quickly. And you can't tell, right, Doc, from just looking at somebody, they're a fast metabolizer or a slow metabolizer, even based upon their history. You got guys who I refer to as steroidians their whole life. They're used to using an anabolic every year, most of the year. And yet some of those people can get away with injecting, every 8, 9, even 10 days and keeping a nice steady titer. To try and pin down a level is, like with most of medicine, very difficult, because it's very individualized. But I think, that's a general rule that I use is I start people with a cc a week of testosterone and titrate it either way from there to, once we see what the results are. What about you, Doc?
Personally, my protocol is 25 milligrams every other day, so it's 100 milligrams per week. And I'm using this because whenever I use a higher dose and less frequently, then I notice that my SHBG is crashed from the higher dose of androgen. That leads to higher free testosterone aromatization. So I need more aromatase inhibitor in case I use higher dose but less frequently. Also, DHT spikes less if you use smaller and more frequent doses. And DHT also relates with erythrocytosis and hemoglobin production. First, when I started HRT in TRT in January of 2015, I was using once a week 125 milligrams, the half of testosterone 250. And it took me a lot of weeks in order to stabilize my testosterone, plus the fact that the day before the shot, I was hypogonadic. My levels, the 7th day, the 6th day, were super low. And then when I was using 100 milligrams, the following day, I had a spike. So this had fluctuations in my estradiol and my mood, and I had to use more Arimidex. And the more Arimidex you use, then the lower HDL can become. Also, if you crash on estrogens, then you have mood swings, and maybe the erection is not very prolonged and good. And also you have joint ache, and maybe not so much glycogen synthesis and pumping. So estradiol is I believe, is the moderator, and it relates also with free testosterone and SHBG. So you have to keep it stabilized. And too low, of course, SHBG will lead to higher free testosterone. The point is that free testosterone is the most important, this 2%, which is free and is not bound to SHBG. But the point is that aromatization and estradiol is the result of free testosterone. So everything has to be under control. And I have realized that even every day or every other day, depending on the ester or propionate or enanthate, if I go over 150 milligrams, then my total testosterone goes over 1,000. And okay, I feel more jacked, but I have erythrocytosis more often, and my nipples hurt a little bit. Therefore, my best is, what works for me is 100 milligrams every other day, 25 multiplied by 4. So Monday, Wednesday, Friday, and then Sunday, and then goes on.
Yeah.
Yes.
Gotcha. All right. Well, I'm gonna. Any last word, you guys? I want to let you go about your day, Dr. Rand, and Dr. Go to bed for Dr. George over here. But any last advice for the people out there? And I guess taking blood tests and being followed by your physician is like not being afraid of going to see for tests. I think is the problem with bodybuilders. They never want to go see what's going on under the hood. I think that's the major problem. Don't you agree, guys?
It's definitely a part of it, because in this country anyway, the profession frowns upon anything that goes outside the norm. Medicine here wants to get you from diseased to back to eased, and we know that it's not just about getting back to normal anymore. There's another option to get back to optimal, wherever that is on the scale of things. And it's an insurance-based system here. Doc, you can explain, maybe a little bit more just out of interest what happens in Greece in your system. But here, yeah, you're frowned upon for doing anything that's outside the norm of standard of care, even if there's lots and lots of documentation that it's better for you. But if I may, and I'd like for Doc to have the last word here, but I think, in keeping with the idea of, the program about, heart disease and use of testosterone and or anabolic steroids, I think you hit upon the take-home messages. There isn't necessarily an answer, an ideal. There are general guidelines, and Doc was very, very specific about a lot of the things we can measure and the ranges which we want to hit, and the things we can do to change those. Everybody's a little different, and the main thing is to get in there, as you suggest, Dave, and get the data and find out, okay, where do I stand? I may be more predisposed to inflammation, so I better focus on eating, more vegetables and definitely eliminating, most of the saturated fats. Whereas, George may not be the same. And you say, well, yeah, I don't have to eat as many vegetables, although you're blessed and living in the Mediterranean area yourself, so it's probably easiest for you to do the right things. But you know what I'm saying? Maybe he can afford to eat more butter than I can. Just use very simple examples. But the key is to get the data, plug into the system, and get the information, and then you can start manipulating it. If you don't have the information, yeah, you can kind of hit or miss it and say, as a general rule, yeah, taking just to make it easy, a B complex, so you make sure you're getting your folic acid, your B12 to lower homocysteine. Sure, it's a good idea, but you may need even more than a standard dose, or maybe you don't need to focus on the vitamin B so much. You need to focus on something else, and you won't know that unless you do the testing. So again, the take-home message is don't guess when you can test. Go to your doctor. If your doctor gives you a hard time or sticks his, he looks down his nose at you or her, she does it, then find another doctor and be an advocate of your own health. But get in the ball game with the numbers and the testing, and then go from there. Doc?
Yes, absolutely. I mean, the medical world, the medical society in my country is also skepticistic and suspicious. And they listen with prejudice, all these things. And basically, endocrinologists do not believe in hypogonadism and this decline of hormones. They also believe that after ceasing the steroids, there's no withdrawal symptom and the things will catch up eventually someday, which is also a mistake. Mm-hmm. I also am a big advocate of blood work before a cycle and after the cycle. And make sure that if you want to enter a cycle, your lipids, your liver, and your CBC are fine, and your kidney also, GFR and urea creatinine. And through the cycle, you have to use prevention supplementation, not smoke, eat healthy, and do a regular daily cardio exercise for the heart, not so much for the caloric expenditure. And of course, afterwards, we have to see what damage is done. And after the PCT and the post-cycle therapy with HCG and SERMs, then we have to evaluate the lipid panel, the kidney metabolism, and the renal, the hepatic also panel, and of course any case of erythrocytosis, homocysteine also, glomerular filtration rates. These are standard factors that they can fluctuate and they can mess up through the process of a steroid cycle. Also, an ultrasound, a heart ultrasound, will reveal any possible left ventricular hypertrophy. And of course, as Dr. McLean said, the ultrasound of triplex of carotid arteries that are related with calcification of coronary arteries. And eventually, the calcium score will reveal any stenosis and occlusion in the coronary arteries. Personally, I had a stenosis, a calcium score, because I was a big abuser of decadurabolin. And I believe nandrolone is responsible for calcium reabsorptions in renal tubules. Therefore, in the long term, this may lead to calcification. However, my brother-in-law, who's a cardiologist, told me that a calcification and calcium score is a better scenario rather than have the atherosclerotic plaque, which is unstable and can eventually occlude and do an embolism. So a calcium score and a calcification is a steady and something that does not get detached, so it cannot make a thrombosis. That's all. I mean, I have nothing more to add, and I completely agree with Dr. Ron McLean. And prevention is the key to longevity.
Yeah, I'm glad you guys are both on the same page, and obviously, so that carotid thing should be the first thing to do for someone who's just watching this video for the first time and say, okay, well, obviously I've been doing this for a while, and I just want to make sure if I'm at risk. Now that should be the first thing to do. It's not invasive, Doc. It's pretty easy to test, that carotid thing.
It's the same one they use. They actually refer to it as a one when they're checking a fetus in a pregnant woman.
Oh, wow.
It takes, if someone's slow, the operator is slow, 15 minutes of your time.
Wow.
It's good feedback. Yeah.
That's awesome. So maybe that's what people should start, and, start preventing instead of waiting to, have to go to the emergency room. Or, I mean, obviously, we've been doing this for a while, but I think, more and more the information is available, and I really thank you both for taking the time out of your day to putting the right information out there and possibly preventing more issues or more, heart attacks.
And thinking of Eric and some others too, just because it's happened doesn't mean, like, if you skip the preventive care part and you got to the part where you had an MI and you survived it, et cetera, it's not too late either. We talked about this before the show. We can certainly halt and even reverse coronary artery disease in the case that Doc referred to. Once it's calcified, it's stuck there. It's not going anywhere. But that's not the dangerous stuff, as he alluded to. The dangerous stuff is a soft plaque, and that can be reversed. It can certainly be halted for sure, but can even be reversed. So just because you've had a problem doesn't mean your life is over and you're going to have to, relegate yourself to the injured reserve list and, be a couch potato. You can get back in the game. You just got to do it differently.
I'm glad you're saying that. This is directly for you, Eric. I hope you heard him because he's not waiting, to see what's going to happen next. I'm glad you brought that up. Dr. George, thank you so much for coming on the show. Dr. Rand, I really appreciate having you both on this program. And I hope that we get to do this again sometime in the future.
Please,
Yes.
yeah. Hey, Doc, it was a pleasure, to speak with you here and share the ideas. I hope we can do it more often, please. If Dave can arrange
Yes.
it.
I was very honored to speak with Ron McLean. I mean, I was watching his videos some years ago, and even in my wildest dreams, I couldn't believe that one day I was talking online with him and on South.
I told you we're a rock star, Doc.
Hey, you know what? No, in all seriousness, this is the kind of stuff that has to happen more often. If we can find more docs that have gleaned a lot from practice and have followed these things like Massimo and others.
Yes.
Let's get on the same page and share the information, because we're not going to get it from the medical school texts. It's not part of mainstream yet, not because it doesn't work or, it's just, it takes a long time to bring it into the fold. And with advances that we have in medicine, technology, of course, this is the way it's going to get out there much more quickly and safely, I would argue, too.
Doug, I have mailed you my book. I hope you got it.
I have. I don't know if I shared with you, but I was in.
Okay.
I was in surgery. I had another spine and ulnar transposition revision just 2 weeks ago. So I've been kind of conked out, but I do have a copy of it in the office. We received it, I think, last week. Thank you very much.
You're welcome.
Where can we find your book, Dr. George?
It's on Amazon, and it's called The Good, the Bad, and the Ugly. It's sold by Amazon, and it's the improved edition of the PD used in sports, which was released last year. Nice. And also, I was honored to contribute on Anabolic's book.
Oh, nice.
Bill Welling, yes, and I wrote the chapter of intramuscular abscess because I was also a victim of contaminated steroids once upon a time.
Wow. Oh, we're going to have you back on the show, that's for sure.
That's a big one. That's a big one to talk about. Yes. Doc, your book didn't get in the screen, so that the latest.
Yeah, don't move it. A little more.
There you go. More.
There you go.
There you go.
Oh, wow, look at that. He looks good, too. Wow. Just
But
like Doc friend. You guys both look great. Awesome. Well, thank you so much for being on the show, you guys. And I can't wait to have you back again. And then thank you both very much.
Thank you. Talk soon, Doc. Dave.
Bye-bye, Dr. Ron McLean.
Bye, Doc. Thank you.